Hello, everyone. Thank you all for joining us today. I'm Judy Rose, pronouns she, her, and I will be your moderator for today's webinar. So to start off, we have a couple of logistical items. First, if you have any questions for our speaker, please type these into the Q&A chat. To access this chat, look for a button at the bottom of your Zoom screen. It is marked Q&A and has a question mark. At the end of today's Q&A, we will be joined by a special guest, AHA's Chief Medical Officer, Dr. Jessica Vogelsang. She has a very special announcement, so be sure to hang out for that. And if you would like to participate during today's event by sending a reaction emoji to something that our speaker says, you can do so by clicking on the heart at the bottom of your Zoom screen. So let's try this out. Send a heart emoji if you're excited that it's finally October. Oh, lots of hearts coming in. And if you would like to obtain a CE certificate following today's event, you must fill out the quick survey that will be provided following the event. The survey will either pop up on your screen or you will receive an email following the event with a link. All right, so I would also like to thank today's sponsor, Boehringer Ingelheim. Without them, today's webinar would not have been made possible. So thank you so much, Boehringer Ingelheim. So to start things off, we have a super short activity for you. I'm going to share my screen. And up on the screen, you will notice a QR code. So if you could, please scan that QR code and take a super quick questionnaire to help us out for today's presentation. And enjoy the beautiful picture of Colorado that I took yesterday of all the fall colors that are here right now while you're taking that quick questionnaire. So we're going to pause for a moment so you can do that. All right. So I'm going to go ahead and let our speakers share their screen. And without further ado, I would like to introduce you all to today's speaker, Dr. Jane Sykes. Dr. Sykes, take it away.
Thank you very much, Judy. Can you hear me okay?
I can hear you just fine. You sound great.
Excellent, thank you. Well, I firstly want to thank AHA for the opportunity to deliver this presentation on leptospirosis, and I also want to thank Boehringer Ingelheim for their support of this event. Thank you all for attending. I hope I can provide you with some useful tips that you can immediately take away to your practices today. So just a quick conflict of interest disclosure. I do receive honoraria or research funding from a number of industry groups that do make leptospirosis vaccines or diagnostic tests for leptospirosis. So I just wanted to quickly declare that now and also thank them for their support of my work. All right, so to give you an overview of this 1-hour session on leptospirosis, I'm going to give you an introduction to the updated ACVIM consensus statement for those of you who are not aware of that yet. And then we'll talk about new information regarding the epidemiology of leptospirosis and how the organism is capable of causing disease. We'll talk about the important difference between reservoir hosts and incidental hosts. Then we'll talk about an update on diagnostic testing. We'll discuss prevention, including vaccination, recommendations on treatment, and if we have some time, I'll incorporate some case examples as we go along. So leptospirosis is a globally important zoonotic spirochete disease caused by the pathogenic spirochetes of the genus Leptospira. It's currently estimated that leptospirosis causes disease globally in more than 1 million people per year and accounts for more than 60,000 deaths. Now, those numbers actually don't seem very high when you compare them to the numbers reported for diseases like COVID. But leptospirosis is a really non-specific febrile illness, and it often goes undiagnosed or misdiagnosed. And in fact, it can look just like COVID as well. 70% of cases worldwide occur in tropical regions, and it's often in countries where there's rice paddy farming and you have animal contamination of irrigation waters, and also people walking around in those waters with bare feet or abrasions on their skin, which promotes infection with the spirochete. Now, in dogs, regardless of the geographic location worldwide, leptospirosis continues to be a significant cause of multisystemic disease. And that's going to be one of the take-home points of this presentation, is that although we think about leptospirosis as a cause of acute kidney injury and maybe liver disease in dogs, the organism can actually affect every organ in the body. And so you should be considering it whenever you see a dog that has acute multisystemic illness. And despite the fact that we have really good vaccines for leptospirosis now, outbreaks continue to occur, even in places that you might not expect leptospirosis to occur. And really, these outbreaks are entirely preventable through improved vaccination. I'm also really fascinated by this disease. It is a quintessential One Health problem because it requires consideration of a huge variety of different animal reservoir hosts, as well as the pathogen, the persistence of the pathogen in the environment, and incidental hosts like dogs and people. So in terms of outbreaks that have been ongoing in the United States, several years ago, we saw the appearance of an outbreak of disease in quite arid parts of the country in Arizona. And so you can see this report of leptospirosis cases on the rise in Pima County in Arizona. There's also been outbreaks in the Chicago area. In the last couple of years, there was an outbreak in West Los Angeles County and another outbreak in Wyoming that received media attention. And oftentimes these outbreaks have occurred in regions where vaccination is not being performed because there's a perception that because these regions are more arid and not the typical warm, humid type of environment, leptospirosis is unlikely. So as an introduction to the consensus statement, we published a small animal consensus statement on leptospirosis back in 2010. And since that time, there's been considerable changes in diagnostic testing for leptospirosis, treatment, and also vaccines. So it was time for an update. So we proposed the updated topic to the ACVIM Board of Regents. And then a panel was established, and we also recruited raters or voters, additional panelists who voted on the statements in the consensus statement using this method known as the modified Delphi method. And then we presented the consensus statement at the 2023 ACVIM forum and obtained input on the recommendations there. And then the draft statement was posted on the ACVIM listserv for comment. And largely, there was a lot of support for the statements made. So you will see that this really truly was a consensus statement. You'll see the level of agreement for each of the statements. I'm going to be presenting in this talk as the number of people who voted and the number of people who agreed with the statement. And largely you'll see that we almost had 100% consensus for many of the statements, with a few people who didn't vote because they didn't feel like they had enough understanding of the specific recommendation area, or a few people that had concerns that there was not enough evidence maybe to support some of the statements made. But you'll see the level of agreement reflected in this talk. All right, just a couple of comments about the taxonomy of leptospires, because there are some aspects of it that are relevant to clinicians. The taxonomy of Leptospira has been completely revised in recent years, and now we have 68 different genus species that are divided into two clades, the pathogens and the saprophytes. And so only the pathogens are capable of causing disease in mammals, and they're divided into the P1 pathogens, which include the most virulent species like Leptospira interrogans and Leptospira kirchneri, which cause the majority of disease in humans and animals. And also these P2 pathogens, which are increasingly recognized as being capable of causing disease, including in dogs. And the reason this is relevant is that some of the PCR tests that are currently available do not actually detect the P2 pathogens. So there may be some cases that we miss when we use PCR for a diagnosis. Now, among those genus species, we have hundreds of different serovars that are identified based on their outer lipopolysaccharide antigens. And so you will know some of these serovar names because they're included in our canine vaccines, like ictohemorrhagiae and grippotyphosa. And antigenically related serovars are grouped into serogroups that have related outer polysaccharide antigens. But the problem is because the serogroup just reflects the outer coating of the spirochete, you can have two completely different species of Leptospira that are genetically very unrelated that actually have the same serogroup name. So you can find grippotyphosa in both enterogans and kirschneri. So that means this method of classification is extremely confusing. And so there has been a move in the leptospirosis world to more sequence typing, based on genetic sequences. But we still need to know about serogroups and serovars because vaccine-induced immunity is serovar specific. And we've associated certain serovars in the past with certain reservoir hosts like rats and icterohemorrhagiae and dogs and canicola and raccoons and skunks with grippotyphosa, for example. But what we're learning is that these types of associations are really loose and you can actually find the same serogroup across multiple different reservoir host species. In fact, in different parts of the world, there's probably tighter associations between sequence types and certain reservoir hosts. And so because of this loose connection between serogroups and different reservoir host species, one of the first statements that we make in the consensus statement is that dogs should not be assumed to be the reservoir host when serogroup canicola is identified or suspected as the cause of disease. And there you can see the level of agreement, which was 12 out of 12 voting members. And you can see these three papers here document the detection of serogroup canicola in rodents or small mammals on the left and horses and pigs on the right. Worldwide, the most important reservoir hosts are rodents, especially Norway rats. And there was one big review that looked at all the papers on lepto in rodents and showed that worldwide, the prevalence of infection in Norway rats was about 30%. So if you see a brown rat, there's about a 30% chance that that rat is shedding pathogenic leptospires. So if you go and eat out and see some rats running around now, you can think about leptospirosis. And in some parts of the world, such as in resource-poor countries, in tropical regions, as many as 80 to 90% of Norway rats may be infected with pathogenic leptospires. But of course, other wildlife and domestic animal species are also important in terms of the epidemiology of the disease. And I love this app. It's been featured in the news that you can track rodents in the New York City subway. And it's quite fun to play with. They have their ratistical analysis, which I also think is clever. And so you can, if you're in the subway system, you can report rodents, and it's this crowdsourcing app that I've probably spent way too much time playing with. The New York City Department of Public Health has also drawn attention to the problem of leptospirosis in light of the growing rodent problem in New York City. And they note here on this webpage that rats are the most common source of leptospirosis. And they make recommendations such as always wearing your shoes when taking the trash out, maybe something that you don't think about in terms of getting infected with leptospirosis. And also some media attention to the problem in dogs in New York City too. And so if you think back 10 or 20 years, we were really thinking about leptospirosis in middle-aged, large breed dogs that were frequenting rivers and lakes or had outdoor exposure on farms. But now we know that we're seeing more and more leptospirosis in small breed dogs, as well as dogs living in urban environments like New York City. And because of that, the statement is made that all dogs are at risk of leptospirosis, regardless of signalement, geographic location, lifestyle, or the time of year. And everybody agreed with that statement. And in fact, it may be that the reason why we're seeing more leptospirosis in small breed dogs from urban environments is because this is the population of dogs that has remained unvaccinated. Now, I get a lot of questions about lepto in cats. I'm not going to spend much time talking about cats and lepto in this talk, but cats can get leptospirosis and develop illness that looks very much like illness in dogs. However, they do seem to be quite resistant to clinical disease, and there's only been a small number of cases reported in the literature. There have been some recent studies looking at feral or free-roaming cats to determine whether they could be shedding organisms subclinically, especially given their predatory activities. And this one particular paper from Western Australia documented as many as 45% of free-roaming cats as being infected, having renal infection. We did another study recently looking at cats in California and Texas, and we only found that 10% were seropositive, and we didn't find any evidence of urinary shedding using PCR. But we do make the statement that cats may be an under-recognized source of pathogenic leptospires in some regions and should be considered in One Health investigations that employ sequence typing methods to advance our knowledge of the epidemiology of the disease. All right, so another really important thing that I get asked about by clinicians and veterinary technicians is about the organism and its survival in the environment, especially if people are taking lepto suspects outside to urinate around their practice. Do they need to be worried about contamination of the environment and potentially infecting people or other dogs? Well, certainly there's been associations between increased rainfall and flooding and outbreaks of leptospirosis. We all know of those associations, and certainly with all the floods that have occurred in the Carolinas this last weekend, definitely we should be worrying about maybe disease occurring several months from now, because that's typically the pattern, is that you get flooding or high rainfall and then outbreaks of disease 2 to 3 months later. And we probably are starting to understand why there's that delay. It seems that the organism is capable of replicating now in the environment and also forming biofilm on substrates. And so waterlogged soil is really a great environment for the organism, probably because it is able to form that biofilm and persist at high levels in that way. And so it may be that the reason why we see these outbreaks occurring weeks to months after flooding is because it takes that long for the organism to replicate in the environment and form that biofilm. We also used to think that freezing destroyed the organism, but now we know that leptospires can actually survive freezing. You can culture them from frozen rodent carcasses, for example. And so while the viability of them is decreased during periods of freezing, they can still persist during that time and then subsequently cause infections later on. And in some parts of the country, there are seasonal effects of leptospirosis, but in parts of the country where it rains all year round, you could see leptospirosis all year round. And this is a really nice study. It was done a while ago at Purdue, where they used serologic data from large numbers of dogs to show differences in the temporal pattern of leptospirosis. So you can see that in the Midwest and the Northeast, you see more cases during the fall, right about this time, case numbers actually start to go up. But where we are in Northern California, we actually see most of our cases in February, March, April, after heavy rainfall has occurred. Now, if you decided to try to go out and get leptospirosis tonight, by, for example, eating some rodent kidney tissue. That would be a pretty good way to get infected. Then the organism is going to be able to penetrate your body through intact mucous membranes. And as I mentioned, with these people who have abraded skins that are waiting around in rice paddy fields, the organism can penetrate through abraded skin as well. And so you can see in this little graphic that was provided to me by Dr. Simone Schuler that how the organism is capable of penetrating endothelial cells and invading tissues. And then we see acute, followed by potentially chronic kidney injury, as well as hepatic injury. And you should note that it is a cholestatic hepatic injury that occurs with leptospirosis. It's not liver failure as such. So if you see a dog that has really high liver enzymes, for example, a dog that looks like it could have mushroom toxicity, is hypoalbuminemic, hypoglycemic, hypocholesterolemic, that's not likely to be leptospirosis. Typically, we see mild to moderate increases in ALP and ALT, increases in total bilirubin, but not like fulminant liver failure. And so if you ate that rodent tissue tonight, you could expect to become sick about a week from today. So the incubation period is typically about a week long, although sometimes it can be shorter than that and sometimes longer than that. But this image here from the West Los Angeles outbreak on the left-hand side is a dog that had vasculitis secondary to leptospirosis. And you can actually see the entire distal portion of this dog's tongue has necrosed off. And when they picked up the dog's tongue with forceps, the entire distal half actually dropped off. So that's a really nice example of the vasculitis that can occur. Obviously horrible for this dog. And this dog amazingly was still able to eat. It has a feeding tube in there, but was still able to eat despite that. And then the other thing that we know now about lepto that we didn't previously used to know is that not only can it form biofilm in the environment, it can also form biofilm in tissues. And it's formation of biofilm in the renal tubules of reservoir hosts that really allows those hosts to chronically shed organisms for long periods of time. So there's not much inflammation going on. There's just the renal tubules are just thickly coated with this biofilm of spirochetes. And not only does biofilm occur in the renal tubules, it can also occur in other tissues. And we've recently come to understand that equine recurrent uveitis due to lepto is from biofilm formation during the eye and we used to think that that was an immune mediated condition, but now we know that it's about the persistence of organisms, and that completely changes how we treat this, right? Because now we're thinking about putting intraocular antimicrobials so that we can directly attack that biofilm as opposed to using immunosuppressive drugs. Now, because leptospirosis can progress very quickly within 24 to 48 hours to acute kidney injury that may be irreversible, we go so far in the consensus statement as saying you should always be thinking about lepto in dogs with acute onset of febrile illness, especially if they're not vaccinated for leptospirosis or very overdue on vaccines. And owners of such dogs should be instructed to come back for a follow-up examination and biochemical testing should their dog's condition not improve within 24 hours. And if the regional incidence of lepto is high or the history does really strongly suggest lepto, you might even want to think about a short course of treatment with doxycycline or amoxicillin, just because if you don't do that and those owners delay return, there may be irreversible renal damage. Of course, we're also concerned about antimicrobial stewardship here, but everybody on the panel that voted on this statement agreed that this should be considered given how quickly this disease can progress. And not just the kidneys and the liver are involved, as I mentioned earlier. You can see lung involvement, which is called leptospiral pulmonary hemorrhage syndrome. You can see pancreatitis. And on the right-hand side here, this was an Australian cattle dog that had leptospiral pancreatitis in addition to acute kidney injury. And you can see its pancreas on ultrasound looks just like a dog with acute pancreatitis. That is unrelated to leptospirosis. So you should be thinking about lepto in dogs with pancreatitis and acute kidney injury. We can see ocular involvement like uveitis, cardiac arrhythmias due to myocarditis, gastroenteritis just because of the effect of the organism in the intestinal tract. We've seen some dogs, especially puppies, develop calcinosis cutis following recovery from infection, which may be related to vasculitis within the skin. And I want to thank Dr. Thierry France, who was one of the panel members, for putting this slide together. But he brought together the laboratory findings from 20 different studies of dogs with leptospirosis, including 868 dogs. And you can see just how varied the different laboratory abnormalities can be. Because of leptospiral pulmonary hemorrhage syndrome, and because some dogs can have this without clinical signs of respiratory disease, we recommend that thoracic radiographs be taken in all dogs that are suspected to have lepto, because these findings can help you with a diagnosis of lepto if they're present, and they should also prompt careful fluid therapy and close monitoring of respiratory function, because these dogs are predisposed to getting pulmonary edema and overhydration. Despite the variation in laboratory abnormalities, there are patterns of clinical signs and laboratory abnormalities that should really help a clinician think about leptospirosis as a possibility. And these abnormalities on the slide are all in conjunction with evidence of renal injury. So if you see a dog that has evidence of renal injury with any one or more of these other findings, you should really be thinking about leptospirosis. So the pulmonary involvement, generalized lymphadenopathy, reluctance to move because of the myositis that dogs with lepto get, this early fever that then breaks, which is very characteristic of leptospirosis, abdominal pain, which results from myositis, pancreatitis, gastroenteritis, and renal pain. And then on blood work, commonly we see a mild to moderate thrombocytopenia, often a normal potassium rather than a high potassium, as you would expect with most causes of acute kidney injury. And that's because the spirochetes actually interfere with the sodium potassium ATPase in the renal tubules, and it causes a greater loss of potassium than you would expect. Often we see increased CK due to the myositis, and glucoseuria in the absence of hyperglycemia is a really common finding as well. And of course, you can see that with other causes of acute tubular damage, like ibuprofen toxicity, but it is really common with lepto, and you should always think about lepto if you see a dog with AKI and glucoseuria. And so these patterns of abnormalities have really lended this disease well to development of a machine learning algorithm. Dr. Crystal Reagan, who's a faculty member with me here at UC Davis and was my infectious disease fellow before that, has been training a machine learning algorithm to help with diagnosis of the disease. And so that's just a really cool application of machine learning and artificial intelligence. And we hope that our medical record system will soon be able to alert us based on laboratory abnormalities that a dog could be a lepto case. And Adolf Wheel was a German physician who was working in Heidelberg in Germany in the late 1800s. And he was employing pattern recognition back then because he noticed that there were 4 people who had really similar patterns of clinical abnormalities with icterus, and he was so sure that they were infected with the same organism, but he was unable to find that organism. And then subsequently, he developed tuberculosis of the throat, unfortunately. And the story goes that when the organism was discovered in the early 1900s, he actually coughed up blood and then died. So quite a dramatic story. All right, so now moving on to a bit more on diagnosis. The gold standard diagnostic test for leptospirosis is the microscopic agglutination test. And so if you've ever submitted serum for leptoserology to a laboratory, this is usually the test that's being done. And so what happens is if you were to eat that rodent kidney tissue tonight and then you got sick in a week from today and you went to your doctor and told your doctor that you thought you had leptospirosis, they would collect your serum and they would submit it to the laboratory where they would make serial twofold dilutions of your serum, and they would react each of those dilutions with a battery of live leptospira serovars. And actually at the CDC, they usually test more than 20 different serovars, whereas most veterinary laboratories are really testing usually only 6 or 7 different serovars as listed here on this slide. And you can understand why. Those laboratory technicians are working with live pathogenic organisms and a huge number of different permutations and combinations of serum and serovars. And so usually you're just testing the minimum number of serovars that you think you can use in order to see a serologic reaction. And when you see multiple positive titers, it's because of serologic cross-reactions among those organisms. So they're looking for the highest serum dilution that causes 50% of the organisms to agglutinate using dark field microscopy as shown on this slide here. Now, this is an example of a 2-year-old intact male Kelpie with suspected leptospirosis. And so you submit blood from this dog that has early evidence of acute kidney injury to the laboratory. The dog's been sick for 2 days, and you can see here's the results. We've got negative test results to 4 of the serovars tested and a weak positive test result to serovar bratislava. So the results are negative in this dog because there's not been enough time for antibody formation to occur yet. And you may actually see all negative titers this early in the course of illness. So what we need, right, is a convalescent test. And so here you can see that the serology was repeated 8 days later. And you would have initiated treatment in the interim, of course. But you can see here that now the highest titer is to serovar bratislava at 1 to 6,400. So this dog's clearly seroconverted, and you can make a definitive diagnosis of leptospirosis. Now, we're all really, really tempted to say that this dog's infected with serovar bratislava. We want to make a diagnosis. But what if I told you that the laboratory then added another serovar onto the test, and now the highest titer is to Pomona at 1 to 12,800? Well, then you might be tempted to say that, oh, it's Pomona, but you could keep on adding more serovars and see higher and higher titers. Sometimes we see titers of over 100,000. And so this is not a serovar diagnostic test. It's just a diagnostic test for leptospirosis. The point of including more serovars is not to diagnose the serovar, it's just to try to detect antibody reaction to the organism. So we state that although leptospirosis has been reported in dogs vaccinated with 4 serovar lepto vaccines, that's really rare. And so other differential diagnoses should be considered more likely than lepto if a dog has been adequately vaccinated for a lepto. And because all of the diagnostic tests that we have available, serology, PCR, point of care tests, really the recommendation is if you're going to try to diagnose infection, that you may need to combine serologic tests and organism detection tests like PCR. We don't recommend that you diagnose lepto based on one single positive MAT test, because you can have dogs that are subclinically exposed to lepto and have positive titers just from subclinical infection. And that could be a completely different cause of lepto in that, of acute kidney injury in that dog, right? So just imagine the situation of your own dog that goes out, gets exposed to lepto, develops positive antibody test, and then eats a bottle of ibuprofen, comes in with acute kidney injury. You do a lepto test, it's positive, but the dog does not have leptospirosis. And similarly, we often see negative tests early on in the course of illness because of that delay in the antibody test, in the antibody production. And we recommend that an interval of 7 to 14 days is used to identify seroconversion and not waiting longer than that or not doing it earlier than that. Really, the only way to know exactly which serovar is involved is to culture the organism and then identify it using serotyping. And the Japanese have published a really nice study where they did this. They had 83 dogs with lepto, and they were able to culture the organism from 45 dogs, which is amazing because it's hard to grow leptospires. You need special media. Sometimes incubation of several weeks is required. And then they showed that serogroup hebdomatis was the most common serogroup involved and suggested that their vaccines should perhaps contain that serogroup to provide better protection from disease. Now, we do also have new point of care tests or relatively new point of care tests that can be used, and many practices are using these tests now. And I remember when I was speaking on leptospirosis 5 or 10 years ago, pretty much no one was using these tests. And now when I'm speaking to an audience, there's a lot of people that are using these tests in their practices. And these are useful, but you've got to understand their limitations. So we have the SNAP Lepto from IDEX Laboratories, which is an IgM and IgG-based test. And we have the Witness Lepto from Zoetis, which is an IgM-based test. And again, just like the MAT test, these are detecting antibodies. So early on in the course of illness, you can get negative test results, and you could see positive test results from previous subclinical infection or vaccination. So when you're using these tests at point of care, you might be working in emergency practice, for example. You could get a negative result, and because you're under pressure, you're busy, you just say, oh, it's not lepto because it's negative. But that's not the case. And in fact, most dogs with lepto early on in the course of illness will test negative using these tests. And then you could also get a positive test result and jump to the conclusion that the dog has leptospirosis when it might be positive from previous subclinical infection. So they're useful. I think the best use of these tests is if they're negative. There's no point doing a MAT test because it's going to be expensive and time consuming. So you might want to wait before doing a MAT test in that situation. And if it's a positive test and it's the witness test, it seems that studies are starting to suggest that if the signs present are consistent with leptospirosis, that's very likely to be a dog with leptospirosis. So we state in the consensus statement that because the sensitivity and specificity of point of care tests may vary from one part of the world to another, we do need more validation studies from these different geographic regions before we can generally recommend that they be used instead of the MAT test. And if you do get a positive test result, that it would be a good idea to quantify the antibody titer using MAT and then do acute and convalescent phase serology to document recent exposure. But a negative test result with any point of care test does not rule out the disease and should be followed with a second test 7 to 14 days later. And we actually just had a dog in our clinic this year here at UC Davis that tested negative using a point of care test. And we really suspected lepto based on the clinical signs. And we just waited 7 days. I think we might have just done waited 5 days. We were doing some serial testing with a point of care test, and we showed that that dog went from negative to positive. So that was a pretty cool example of the use of these tests in that way. And then the other test that we're starting to get better understanding of how it performs is PCR. And we use the term nucleic acid amplification test because not all molecular tests are PCR based, but basically tests for lepto in this country are based on PCR. And we recommend that you collect both blood and urine before you start antibiotics. And in the West Los Angeles outbreak, we had a lot of dogs that tested positive on urine or blood using PCR. So, provided antibiotics haven't been given yet, early on in the course of illness, PCR can be a really useful diagnostic test. And if you get a positive PCR test result on blood and there are consistent clinical signs, that's diagnostic for lepto. But if you get a positive PCR result on urine, you have to remember that some dogs could be subclinically shedding organisms and have renal failure from some other cause. And that's really based on a number of studies that have been done worldwide looking at healthy dogs, showing that a small percentage of healthy dogs can be shedding organisms. In particular, I want to highlight this one of shelter dogs in Tennessee, Virginia, and Kentucky, where these dogs that were tested at shelters, there was quite a high prevalence of subclinical shedding of pathogenic leptospiras. And so that also drives home the point that it's important to handle our patients always as if there's the possibility that they could be shedding a zoonotic pathogen, not necessarily being concerned about lepto in dogs that are acting as incidental hosts. And in the consensus statement, we actually have the very first case definition that we're aware of in a companion animal for an infectious disease. And it's been modeled off the CDC case definition for humans. And by definition, leptospirosis it's an acute disease. So a dog that has chronic PUPD, for example, is not likely to have leptospirosis and would not fit within the clinical criteria that's published in the consensus statement. So you have to have onset of systemic illness within the last 2 weeks and 2 or more of these laboratory findings or imaging findings. And then we've got supportive laboratory criteria here, and then confirmatory criteria here. So if you've just got a single high positive MAT titer, that would be supportive. But if you show a rise in titers over time, then that's going to be confirmatory. Okay, so now moving on to treatment. Based on studies of infected hamsters, research animals, the antibiotic that's most efficacious at removing organisms from the renal tubules is doxycycline. And so wherever possible, doxycycline is the drug of choice. And actually, many of the dogs in the West Los Angeles outbreak were treated only with parenteral doxycycline. So you can go straight to doxycycline, or if you only have oral doxycycline, then the recommendation is to use ampicillin initially if the dog is vomiting, and then switch over to doxycycline, oral doxycycline, once vomiting has stopped. The recommended treatment duration is 2 weeks, and treatment should not be delayed pending results of diagnostic testing. And if you have an animal that has severe renal failure with a IRIS grade 4 or higher AKI, so that's creatinine of greater than 5, the administration interval for penicillin should be doubled. However, the optimal antibiotic treatment is really unknown, and in people, they'll actually treat with third-generation cephalosporins IV because you can give them once a day instead of needing to treat with very frequent penicillin administration. And then there's obviously going to be a lot of other supportive care treatments that are going to be needed. And the consensus statement, if you want to download it from the JVIM website, it's free, a full-length version for anybody. You just Google ACVIM lepto consensus statement. There's some details about some of the other supportive treatments that can be used for these dogs. But I want to just highlight what we say about nutrition. Specifically, kidney diets are not recommended because they have high fat content and they're likely to exacerbate or predispose to pancreatitis and the gastroenteritis that occurs with the disease. So instead, we recommend feeding highly digestible, normal to high protein diets and early enteral nutrition using feeding tubes, as shown in this dog, this cute little Boston here. And obviously pain management as well. And for dogs that are not responding to appropriate fluid therapy, those dogs may need to be referred to renal replacement centers, and that should be done as early as possible. However, obviously that can be very expensive and cost prohibitive for some clients. So prevention is always better with this disease. So let's talk about prevention. First of all, things like rodent control are important and preventing predation. And you may be interested to know that reptiles and amphibians can be reservoir hosts for pathogenic leptospiras as well. It's not just mammals. So stopping dogs from predating, from eating lizards and frogs and things like that can also prevent leptospirosis and reducing access to standing water. Although we do see lots of lepto in dogs from concrete backyards, for example, here in Davis and also San Francisco area. We actually have a lot of backyard chickens in Davis, and so we think that they may attract rodents and also predispose dogs to leptospirosis. Now, there's been several studies published on lepto vaccines in recent years showing that the 4 serovar vaccines are very efficacious and they have a duration of immunity of at least 12 months. It's probably not much longer than 1 to 2 years, though, given that they are bacterins, and some vaccine manufacturers offer a 15-month guarantee. So for dogs that are within 15 months of their booster, if they get leptospirosis, they may cover some parts of the cost of care. But importantly, one of the most important recommendations that's new in the consensus statement is that because lepto is zoonotic, can be fatal despite treatment and can result from exposure that occurs regardless of age, breed, geography, or lifestyle. Lepto vaccines should be administered to all dogs starting at 12 weeks of age, although some vaccines are licensed for use in younger dogs. And that's great because we certainly are seeing more dogs with lepto that are puppies these days. And then an initial then booster vaccination should be administered at intake for shelter dogs because of the reports of infections in shelter dogs. And for all dogs, they should be required by boarding or daycare facilities. And that's been in light of recent outbreaks, the one in West Los Angeles and also the one in Wyoming associated with boarding facilities. But there's no evidence that seasonal timing of vaccination is important because we do have that minimum 1 year duration of immunity. This is a little puppy that we saw at UC Davis that was 3 months old. That was diagnosed with lepto. This has now been published, this case. This is a dog that developed calcinosis cutis as well and had a $20,000 bill because dialysis was needed. Fortunately, that dog survived. And also some studies looking at adverse effects of lepto vaccines showing that really the newer vaccines are very similar to DHP vaccines in terms of their adverse effect profile. When they do cause adverse effects, it's often just local reactions and not these anaphylactic type reactions that we used to see 5 to 10 years ago. So very safe, and hence the recommendations for vaccination of all dogs. And that really changes the way that we practice as veterinarians, because it means that we are moving towards getting dogs back in every year for vaccination so that lepto can be done, unless, of course, a dog's getting annual respiratory vaccines. But that means that all dogs need to come back annually for lepto vaccination. It also gives you the opportunity to do other wellness counseling. And then for dogs that recover from lepto, this is Bodhi here. He's my dog. He likes his lepto vaccine. He's really cute. So for recovered dogs, then we recommend vaccinating them after they recover. They may have lifelong immunity, but we know that these dogs are obviously at risk of infection because they got infected, and we know that immunity is serovar specific, so it's probably a good idea to vaccinate these dogs after they recover. Bodhi thinks so too. And then finally, I just want to mention a little bit about zoonotic transmission and precautions. You're actually much more likely to get leptospirosis from a healthy animal that's subclinically infected and acting as a reservoir host. These incidental hosts that develop severe disease often don't shed very many organisms because they have a pronounced inflammatory response to the pathogen. And there's been a couple of papers published looking at outbreaks and regions where leptospirosis occurs, often like this one from Italy, showing that despite extensive contact with affected dogs, there's really been no evidence of human exposure and infection with seroconversion. So this particular outbreak that occurred in Phoenix, Arizona, the CDC went in and they tested a number of animal caregivers and dog owners that had had extensive contact with infected dogs, many of them saying they weren't taking any precautions whatsoever and they were getting splashed in the face with urine and so forth. And despite all of that, they found 7 people that had flu-like illness, and when they tested them for lepto, they tested negative. So there was some other cause of their illness. And so the risk of transmission of lepto from sick dogs with lepto to people is low, especially when basic precautions are taken. And those basic precautions are listed on this slide and are detailed in the consensus statement. But the big new recommendation is that if you have a lepto suspect, after 48 hours of appropriate antibiotic therapy, you can lift those precautions, which makes it a whole lot easier to manage these cases in your hospitals in terms of infection control protocols. And then we make the comment that apparently healthy dogs, like the shelter dogs, can shed leptospires. So really universal precautions are recommended. Same thing with multi-drug resistant bacterial infections. Just be washing your hands, cleaning up spills, using appropriate disinfectants. And for lepto, that's really any disinfectant because leptospires are really susceptible to disinfection with even quaternary ammonium compounds. So use of accelerated hydrogen peroxide products or any routine veterinary disinfectant product is going to inactivate leptospires. And there's some information on the CDC website for animal owners of dogs that are diagnosed with lepto. The risk to owners is pretty low because before they take their dog to the vet, often they're not shedding organisms in their urine. And then after dogs leave the hospital, they probably had 2 days of antibiotics. But if not, there's some recommendations about owners, avoiding direct contact with urine, wearing gloves and eye protection when cleaning up accidents. And then, of course, referring people to their physician if they have further questions. We also recommend that if there are other dogs in the household that might have had exposure to leptospires, that those dogs should be treated also with 2 weeks of doxycycline, ideally checking their titers at the same time if possible. But in terms of other animals like cats, we really didn't have any evidence to recommend that they be treated as well. This is the information from the Los Angeles County Department of Public Health's website on the West Los Angeles outbreak. And so this outbreak actually involved dogs in a couple of different doggy daycare environments, actually pretty wealthy owners having their dogs boarded at these doggy daycares. And you can see that there was about a couple of hundred cases that occurred. And later, there were dogs also recognized in the community that did not have a history of boarding or daycare. And there was no association with dog parks, but you can see the vast majority of dogs had clinical signs of lepto. And this is the epidemic curve here, showing you that most of the cases occurred in July and August of 2021. And veterinarians in the region were not vaccinating dogs for lepto because they didn't think that lepto was a problem in their region. And actually, the owners of the dogs that were being boarded in these daycare environments learned of this outbreak, and they were actually taking their dogs to veterinarians saying that they wanted them vaccinated for lepto because they'd heard about this on social media, etc. And so veterinarians in the region were having to start vaccinating. And I've spoken to a number of veterinarians who said, I didn't know what to expect because I'd never vaccinated dogs for lepto. And when they started vaccinating with the new vaccines, they realized that they really were not causing any of the adverse effects that they had been worried about. And then subsequently, with cleaning up of the daycares and vaccination, this outbreak discontinued. And because some dogs had really high titers to Serovar canicola, it was thought that maybe dogs were the reservoir hosts, and this was about dog-to-dog transmission in those in the boarding kennel environment. But at the same time, there was a lot of rodents in the area. There was increase in homelessness in the area, and so another possibility was that rodents were the source of infection. But we actually started trying to culture these organisms from the dogs in the outbreak, and we worked with Jarlath Nally in Ames, and he used some pretty cool media to be able to grow the organism very quickly. Within 48 hours of us sending samples to the lab, we were getting positive culture results, and this is just such a cool video. I can watch it over and over again. And we did actually show that this was Serovar canicola in the end, but we still don't really know how those dogs were getting infected. And some of the dogs were reported to have eaten rodents actually as part of their history. So I think I'm out of time. I want to make sure that there's a little bit of time for some questions. So I'm going to stop now and turn it over to questions.
All right, let's take a couple of questions. So, one of the questions I have, if patients are late for a lepto booster, do you recommend repeating the two vaccine series 4 weeks apart?
Yeah, so this is for dogs that are just starting their lepto vaccination program. And they really do need to have that second vaccination 3 to 4 weeks later. So if it gets much later than 5, 6 weeks, then you really probably do need to redo that initial and follow-up vaccine. So that really means that you've got to stress to the owner the importance of them being on time for that second vaccine when you give the first one, and let them know that the protection might not be as good as it could be if they delay that second vaccine.
Thank you. Are vaccines effective against chronic subclinical infections or just acute infections or both?
Yeah, so that's also a good question. Are vaccines effective against chronic subclinical infections? And, in terms of studies looking at that, there haven't been very good studies. It's a great question. But we do know that, for example, dogs that have been vaccinated with 2 Serovar vaccines can develop chronic subclinical infections. If they were vaccinated with 4 Serovar vaccines, we don't know. But certainly experimental infection studies suggest that vaccination can potentially prevent those chronic infections as well.
And how long after recovery would you vaccinate a dog for lepto?
As soon as that dog was well again, at a follow-up, even weeks after recovery, I would go ahead and vaccinate that dog.
And then our last question before our special guest. If an owner reports their dog has having been exposed to dodgy water source and is concerned that the dog has been exposed to lepto but is not symptomatic, should you use doxy or rather wait for symptoms?
Yeah, that is a good question. You shouldn't treat in that situation. And we know that widespread subclinical exposure occurs. And there's also going to be a lot of dogs that are going to have that history and never get exposed to lepto too. So that would lead to probably pretty dramatic overuse of antibiotics.
Oh, thank you so much, Dr. Sykes. Okay, everyone, I would like to introduce you all to AHA's Chief Medical Officer, Dr. Jessica Vogelsang, with a special announcement.
Thank you, Judy Rose, and thank you, Dr. Sykes, for this amazing webinar. Thanks for everyone who came here and also to BI for your sponsorship. I just wanted to drop in really quickly and address something that comes up pretty frequently, which is, as many people know, the 2022 canine vaccination guidelines have lepto as a non-core vaccine, and that was not a consensus from the task force members. Normally, we update our guidelines every 5 years, but in light of the ACVIM consensus statement, we decided to move behind the scenes and do sort of a midstream update. So we reconvene our task force. We go through a whole process to do that. And so you're getting some special information. We don't normally announce these in advance of publication, but in the November-December JAHA, we are publishing an official update to the canine vaccination guidelines to make lepto a core vaccine. We know for many, many folks, having that designation makes it so much easier to get buy-in from your pet owners. So that will be officially live, but you can start telling people now. You can be the influencer out there with the breaking news. So thanks again to ACVA for this work that helped make this update possible for us as well.
Thank you so much, Dr. Vogelsang, and thank you again, Dr. Sykes, and another big thank you to Boehringer Ingelheim for sponsoring today's webinar. And thank you all for joining us. Have a wonderful day and happy October 1st. We'll see you on the next webinar. Bye-bye.